So this is a very high yield topic for the NBME shelf exams. And starting from kind of 10,000 feet up, or a bird's eye view, if the NBME gives you a patient with an acute trauma situation, what's kind of the first thing you want to assess in that patient? So you should be saying to yourself, gee, I really want to be thinking about the ABCs. And what are the ABCs? Well, we'll find out in just a second. So now we'll learn our ABCs of trauma. So here I've listed out A, B, C, and sometimes you'll see D and E included as well. So what do each of these mean? So that's right. So A is airway, B is breathing, C is circulation, D is disability, and E is exposure. So this is also known as the primary survey. Now, moving along with acute management of the trauma situation, in the board exams, if you see a patient with, that's clearly obtunded, what kind of things do you want to consider for the next steps? And I kind of gave it away here, but within the ABCs, A, airway, and B, breathing are really important. So if there's any sign of airway compromise, really want to be thinking about managing the airway, or sometimes even requiring intubation. So what GCS score is required or is kind of an automatic indication for intubation? So if a patient has a GCS score of blank, when do you want to intubate? That's right. So a GCS score of 8 or lower is an indication for intubation. And this is easy to remember because if GCS is 8, then you want to intubate. It just rhymes all on its own. So here is an image I found of intubation. So sometimes you'll have to do this even at bedside if a patient needs acute airway management. All right, sorry, it's Halloween, so I'll be back in a second. All right, let's get right back into it. Just had to answer the door and give out some candy. So here we have the GCS score, or the Glasgow Coma Scale. And essentially this is a way to assess basically how obtunded a patient would be. So there are 3 main components to the GCS scale, or the GCS score, and that would be the motor response, verbal response, and eye-opening response. And I'm not going to belabor the scores too much, but you can see that the motor response is from 1 to 6 points, 6 points being the maximum amount of points from that score. Verbal response is up to 5 points, and eye-opening score is up to 4 points. And the way you can kind of remember that is kind of the motor response is assessing movement, which is the largest part of the body. So that would be the most points, and the eye-opening response is kind of the smallest. This all adds up to 15, so the score ranges anywhere from 3 to 15. All right, so next, still continuing on with our bird's eye view of acute management of trauma situations for any board exams. What's kind of the first line option for circulation or perfusion access in a patient with brisk blood loss? Say they have actively bleeding esophageal varices, or an acute trauma situation like a blunt trauma or a motor vehicle accident. So you should be saying, that's right, 2 large bore peripheral IVs. So that's usually 16 or 18 gauge bore peripheral IVs. Or there is one other option that I have seen pretty commonly tested actually if peripheral IV access is not available. So you should be thinking about an intraosseous line. So that can be typically either in the proximal tibia or sometimes in the proximal humerus as well, especially in trauma situations. Here on the left, you can see an image of IV access, peripheral IV access. I'm sure you've all seen these. And on the right, you have, I can never get this gentleman's names right, but I believe it's Poiseuille's law, Poiseule, Poiseuille's law. But essentially this law states that the flow and the rate of flow is directly proportional to the radius of the tube or of the cylinder to the 4th power, and is also inversely proportional to the length of the tube. So the wider your bore, the way more bang for your buck you're going to get in terms of increase in flow. So here we have an image of his law, and you can see that see here that it actually takes 16 tubes to match the output of one tube when that one tube has double the radius of the 16 tubes. And that's because 2 to the 4th power is 16. So I can put this video link in the description, but really cool demonstration. So this is why you want those large bore IVs. And again, the intraosseous access can be obtained through the proximal tibia or through the proximal humerus, especially in trauma situations, because the proximal humerus is closer to the heart. So it can take, I believe I've read, it can take up to 10 minutes for any, especially if you administer epinephrine through an IO line before it reaches the heart and reaches systemic circulation, whereas the humerus is much closer to the heart. So now, moving on, what is the secondary survey for a trauma patient? So we did our primary survey, the ABCs. What is a secondary survey? So the secondary survey is something we do right away while assessing the patient after stabilizing the patient with the ABCs. And basically what that would be is a head-to-toe comprehensive physical exam and documentation to assess for any other injuries. So that can be things like an arm fracture, hip fracture, anything like that. And then again, with a tertiary survey, that is another head-to-toe physical exam within, usually within 24 hours. And you basically want to make sure and evaluate the patient and do a full physical and really press on different areas of their body to make sure that you're not missing a fracture or any acute injury. So here I just have an example of a finding you may see on a secondary exam, and this is an example of comminuted humeral shaft fracture. So you can find humerus fractures or hip fractures with these secondary and tertiary exams that you may have missed if you didn't do a comprehensive exam. Any SpongeBob fans out there? Look at this neck breaker ride. I always like SpongeBob is, it's kind of underrated. It's kind of like The Simpsons. It really does have an episode for everything, but here you can actually see some vertebrae. Looks like a little bit of a screw going through, maybe a little bit of a fusion after going on this ride. Here you can see some common mechanisms of injury, like hyperextension or whiplash injuries of the neck, especially in motor vehicle accidents. So sticking with our bird's eye view of trauma, what do you want to think about if a patient has had head or neck trauma? What is something that the patient should kind of have, or something that should be put on the patient kind of on the scene or in the field in cases of head or neck trauma? That's right. So you should be thinking that a cervical collar for immobilization of the C-spine is needed or indicated in this situation. Along that same vein, what do you need to do, or what is required in order to clear the cervical spine? Precautions, or take off the C-collar. A set of criteria that's needed. And that criteria is the patient cannot have neck pain, no tenderness to palpation of the midline C-spine or with range of motion of the C-spine, no intoxication, the patient has to be awake and alert, and the patient cannot have any distracting injuries. And again, there's a criteria for this. That's a nexus criteria. Again, the patient cannot have any neurologic deficit, spinal tenderness, altered mental status, intoxication, or distracting injury. Now, if you think a patient has a high likelihood of C-spine injury, or you note something on exam and you can't clear the C-spine because the patient does not fit all those criteria that we just talked about, what imaging study is your imaging study of choice for C-spine injuries? So you should be thinking about obtaining a CT, and this has a very good sensitivity, a very high sensitivity for C-spine injuries, especially fractures. So you can essentially clear the C-spine if the CT is unremarkable for a fracture. Now, another commonly tested question is, why can respiratory status become compromised following a high C-spine injury? So the reason for that is diaphragmatic paralysis, and you might remember that C3 through C5 keep the diaphragm alive, meaning that the nerve roots from C3 and C5 innervate the diaphragm through the phrenic nerve. So when you have a high C-spine injury, you can get impingement of those nerve roots and therefore diaphragmatic paralysis. Here is an image of left phrenic nerve palsy, and you can see hemidiaphragm elevation on the left side, which can be seen following high C-spine injury. So moving on to some specific cases, let's say a patient is presenting with mastoid ecchymoses, clear rhinorrhea, raccoon eyes, also known as periorbital ecchymoses. So what is your diagnosis and the next step in imaging that you want to obtain? So you should be thinking, Mike, this sounds a lot like a basilar skull fracture, and the best imaging test for that would be a CT scan. And again, this affects the petrous part of the temporal bone. You also want to obtain, with this mechanism of injury, you want to obtain both a head CT and a cervical CT, because with this mechanism of injury, there's a high rate of concomitant C-spine injuries. Let's say our next case is an elderly patient admitted following a motor vehicle accident. The mechanism of injury was hyperextension of the neck, or kind of a whiplash injury. They're now presenting with weakness of the bilateral upper extremities and relatively intact strength of the lower extremities. What is your diagnosis in this patient? So you should be thinking about central cord syndrome, and the most likely cause of that is trauma in this situation with that hyperextension, which is best diagnosed with an MRI. And here's an MRI of central cord syndrome. And you can see that lesion kind of near C1 and C2 where the hyperextension occurred, where you see that hyperenhancement on the MRI within the spinal canal. So our next case, let's say we have a 70-year-old woman with a history of rheumatoid arthritis that acutely develops hyporeflexia and weakness following intubation. What is the most likely cause of this weakness and acute decompensation? So you should be thinking about atlantoaxial instability, or essentially C1 and C2 instability in the cervical spine. There is also one other population that has a higher prevalence of atlantoaxial instability. What am I thinking of here? So this is patients with Down syndrome actually have a significantly increased risk for atlantoaxial instability. So in patients with rheumatoid arthritis and Down syndrome, if they have some kind of acute decompensation following trauma or intubation, you want to be thinking of atlantoaxial instability. And here's a picture of that. So that, again, that refers to C1, the atlas, and C2. Next, moving on, we're going to discuss blunt abdominal trauma. Let's say we have a 40-year-old male who's involved in a motor vehicle accident who presents with severe abdominal pain. His GCS score is 13. Vitals are significant for a temperature of 98, heart rate of 120, respiratory rate of 22, blood pressure of 90/60, and he's saturating 99% on room air. On your exam, you note that he has rebound tenderness, and your fast scan at bedside is also positive for free intraperitoneal fluid. What is your next step in management for this patient? And I'll give you a hint. You should get used to saying this as a next step for management on the surgery shelf exam. So you should be saying exploratory laparotomy, or XLAP. Again, like I mentioned, this answer is extremely prevalent on the surgery shelf, so you should get used to picking this as an answer, be comfortable picking this as an answer. Exploratory laparotomy is kind of like pregnancy on the OB-GYN shelf or reassurance on the pediatric shelf. If you don't put XLAP on your surgery shelf, it means something, in the words of divine intervention, has gone terribly wrong. Here's an image of an XLAP. This is a vertical incision, periumbilical incision, and they go in and you can rapidly identify most common structures that cause acute blood loss or are affecting an acute trauma situation. That includes like liver with liver lacerations, the duodenum, and the transverse colon. So you'll be like surgeons are able to run the bowel and identify and take care of any vascular injuries or causes of acute bleeding and acute peritonitis. Now, this is completely a pimp question, but I've gotten asked enough times that I just figured I'd throw it in the presentation. So how much blood loss is required for hemorrhagic shock? So I've heard between 25 and 30% of the blood in the body. And then what is the massive transfusion protocol and when is it initiated? So MTP, or massive transfusion protocol, is initiated when there's anticipated massive blood loss. So anytime a patient is rapidly bleeding or has more than 4 units of packed red blood cells were transfused are required. But usually if a patient is rapidly bleeding, and especially in an acute trauma situation, you want to initiate or think about initiating MTP, because that decreases the risk for coagulopathies that are more common in an acute trauma setting. And what MTP is essentially you call the blood bank and they'll give you red blood cells, platelets, and FFP all in a 1-to-1-to-1 ratio, which are administered at the same time. And the reason for that is because it's actually emulating whole blood, but we don't store whole blood, we just store the blood products. And it has to do with the storage date, and whole blood doesn't last quite as long as the individual products. So you want to administer in a 1-to-1-to-1 ratio, and that's a massive transfusion protocol. And you will basically keep transfusing to try to stabilize the patient. So let's say you have a hemodynamically unstable patient after blunt abdominal trauma. So this is, again, kind of a bird's eye view, but actually in the last patient, I kind of just giving you a hint. The question stem gave you the preferred imaging finding for this type of situation. So you should be saying a fast exam here, so that you want to obtain a fast exam in cases of blunt abdominal trauma in a hemodynamically unstable patient. If the fast exam is inconclusive, what test, and this is really just for exam purposes, can you consider obtaining it at that point? So you can consider obtaining a diagnostic peritoneal lavage, or DPL, and evaluate to see if there's blood in the abdomen. Again, this is more of an exam answer, and you're probably not going to see this in real life. I've personally never seen this done. If a patient is hemodynamically stable, what imaging study could you think about obtaining in that situation? So in that case, you could obtain a CT scan, also called the donut of truth. Here's a quick image of the fast exam. So this is kind of the recommended sequence where you go from the right upper quadrant, left upper quadrant, pelvis, and you can get into the cardiac and lung windows as well. So you can quickly assess for any intraperitoneal fluid or major trauma to the heart and lungs. And here's another diagram of the fast exam. And this is done via ultrasound. So all right, a couple of doorbell rings. I'll be back in a sec. All right, we were talking about blunt trauma at the level of the bicycle handlebar. So what do you want to be thinking about in this situation if you have a patient presenting with this history? So you want to be thinking about either pancreatic injury or also duodenal injury. So just moving on. So let's say you have a delayed injury following some blunt abdominal trauma in children. So maybe 3 days following an initial blunt trauma. What do you want to be thinking about here? So I was thinking duodenal hematoma. So you want to be thinking about pancreatic injuries and duodenal injuries in blunt abdominal trauma at the level of the bicycle handlebars. And for some reason, this is a very common prompt that comes up on examinations. So here's just a quick ERCP image of a pancreatic leak. And here's a CT scan of a duodenal hematoma, and this one is very obvious. So if you see a viscous on a chest x-ray, what's your next step in management? So these are questions you can do in, on UWorld, you'll get that like 5 seconds, because if you see a viscous on the abdominal x-ray or the chest x-ray, what's your next step in management? So you'll be concerned about a perforated diaphragm, and you'll want to take the patient into the OR for an X-lap. And here's an example of a very prominent pneumoperitoneum. Now another patient vignette. So let's say you have a 65-year-old patient that fell off a ladder onto their left side, and now they are presenting with severe pain. Their vitals are significant for tachycardia with a heart rate to 110, a little bit of hypotension with blood pressure of 80 to over 55, respiratory rate is 27, temperature is 97. The FAST exam is showing you intraperitoneal fluid. What is your next step in management for this patient, and what will likely be done during that next step? So you should be thinking about an X-lap and likely splenectomy as well. So the spleen injuries are graded from 1 through 5, and a grade 1 splenic injury is laceration or capsular tear or a small subcapsular hematoma. And this goes all the way up to grade 5, which is either vascular injury, such as to the splenic artery, or a completely shattered spleen. If this patient was stable, on the other hand, what imaging would you want to obtain to assess for a splenic injury? What's kind of the first line imaging study? Yep, so you'll want to be considering a CT scan, and you can consider embolization as well, depending on the severity of the splenic injury. Now, we do vaccinate patients that have a high-grade splenic injury or splenectomy, and what is the ideal timing for vaccination, and what do we vaccinate these patients for? So usually what we do in the hospital is we vaccinate patients prior to discharge. Technically, the literature suggests that 2 weeks following splenectomy is the optimal timing for vaccination against what organisms? The shin organisms. So that'll be for any asplenic patients, you want to think about vaccination against strep, pneumo, H flu, and Neisseria, because those are your encapsulated bacteria. Here's an image of a major splenic trauma. This is actually a grade 5 splenic injury. And again, you want to consider vaccination against encapsulated organisms, your shin organisms. So let's say we have your next case is a 40-year-old gentleman who is presenting with a GSW to the abdomen at the level of T8. The exit wound is not visualized on your exam. So what will be the next step in management for this patient? A lot of trick-or-treaters tonight. So your next step in management would be again, X-lap. Like I said, you want to get comfortable picking this answer. So any entry or exit wound below T4 essentially involves the abdomen. So you want to do exploratory laparotomy in these cases. All right, so next, let's say they give you a 45-year-old patient that has a penetrating wound and is hemodynamically unstable and has no rebound tenderness, and it's kind of on the lateral flank. So what is your next step in evaluation of this patient? Again, this question refers to exam purposes. So you want to think about local wound exploration. So you can use kind of the gloved finger and probe within the wound cavity, and you're evaluating for peritoneal involvement or any organ injury. if the patient is unstable or they have any peritoneal signs, what's the next step in management? Yeah, it's an X-lap. Like I said, get very comfortable with this answer. One other situation that I've seen tested is if there is a stab near the heart, then you want to think about hemopericardium or a cardiac tamponade as well. All right, we move on to chest trauma. And here's a common mechanism of injury of chest trauma. Again, motor vehicle accident with acute deceleration. The steering wheel is kind of at the level of the chest. So let's say our first case vignette, let's say they give you a 35-year-old male following motor vehicle accident that's now presenting with hypotension, tachycardia, severe chest pain, and a widened median sternum on the chest x-ray. So you should be thinking about traumatic rupture of the aorta in this situation with the hypotension, tachycardia, and the widened median sternum. Treatment for this is, well, you're taking a surgery shelf, so you can kind of guess what the answer will be for that. Or from that, rather. So it'll be open surgical repair with thoracotomy. So that'll involve cracking the sternum and going with an open repair and trying to stabilize the bleeding and stabilize the aorta, or with kind of surgical repair. All right, let's say they give you a 28-year-old football player that's hit in the chest and then suffers cardiac arrest. So what is the likely diagnosis in this setting? So you should be thinking about commotio cordis, which can happen with acute trauma to the chest. And what's the most common arrhythmia associated with commotio cordis? So that would be VFib, or ventricular fibrillation. And commotio cordis, the pathophys, essentially involves blunt trauma at a part of the heartbeat cycle that is vulnerable, and that causes acute arrhythmia. So the most common part of the heart that is commonly injured, what chamber of the heart is most commonly injured in commotio cordis? Or in general? It's the right ventricle. And why is that? It's because it's the most anterior structure, or the most anterior chamber of the heart. And the above clinical vignette was the story of Damar Hamlin. He was a Bills safety that suffered commotio cordis during an NFL game on national television. So next clinical vignette, let's say they give you a patient presenting with tachycardia, elevated JVP, hypotension, and they're unresponsive to fluid resuscitation, and they now have an arrhythmia 3 days after blunt chest trauma. What is your likely diagnosis in this setting? So you should be thinking about cardiac contusion, and some tests that you can obtain in this situation are EKG, echocardiogram, and troponins. Here's one way that I always kind of remember blunt cardiac trauma. So I don't know if any of you watch this World Cup, but this is French legend Zinedine Zidane, and he famously, or infamously I should say, headbutted one of the Italian defenders during the World Cup final. I was actually watching this game, so this is always vivid in my memory at least. So next case, let's say they give you a 60-year-old gentleman that fell down the stairs and now has left-sided chest pain. And on exam, you note tenderness to palpation of the left chest wall, and they give you this chest x-ray. What is your likely diagnosis? And for anyone that hasn't watched the other videos that we made, we do recommend kind of a protocol in reading chest x-rays. It's very simple. Again, the ABCDE method, which stands for airway, bones, cardiac window, diaphragm, and E stands for everything else. So if you use that here, you can kind of see that this patient has a positive arrow sign, and that in this specific situation is indication. So you see they have a rib fracture. So they have a T7 rib fracture. The treatment for rib fracture is shockingly high yield for examination purposes. So what is treatment for a rib fracture? So the most important tenets of treatment for rib fracture include actually adequate pain control and inhaled spirometry. And the reason for that is because patients with rib fractures can develop shallow breathing due to pain, and that can make these patients more prone to atelectasis and pneumonia, etc. So you really want to make sure the pain is well controlled. Typically, these rib fractures are treated non-operatively, although there is one setting that is a potential indication for operative management. And we'll talk about that right now. So let's say this patient had continued hypoxia, but they actually had multiple rib fractures that you saw on the chest x-ray in multiple contiguous ribs. So you should be thinking about flail chest, and the mechanism of that is actually paradoxical inward motion of the chest wall or the chest cage during inspiration. And this is a pretty high yield question. So how many contiguous fractures are required for a diagnosis of flail chest? That would be 3 fractures in contiguous ribs. And here is one example of a flail chest. So you can see multiple rib fractures on contiguous ribs in 2 separate locations. So for our next case, let's say they give you a 60-year-old gentleman that again fell down the stairs and now has left-sided chest pain and dyspnea. On your exam, you note that this patient has absent breath sounds on the left side and an elevated jugular venous pressure, JVP. What is your next step in management? So you're going to be tempted to say chest x-ray, but the correct answer in this situation would be needle thoracocentesis, because this has kind of tension pneumothorax physiology, especially with the elevated JVP. So you really want to be thinking about acute management in this situation. You can consider a chest tube in stable patients that do not have tension physiology, where you would get a chest x-ray and maybe put in a pigtail chest tube, and then reassess later for resolution of the pneumothorax. But in acute situations, you want to consider needle thoracocentesis. And here's an image of massive pneumothorax. So you can see the absence of bronchial markings on that left side. See how it's completely lucent, that left lung. There's complete lucency of that lung. So that would be what a pneumothorax looks like. Usually they're not this prominent on exams. Usually they're a little more subtle. But I just wanted you to all be able to kind of see a very obvious one. So let's say a patient has an open chest wall injury with pneumothorax. What is some non-invasive management if this is a sucking injury? So you can consider partially occlusive dressing, where you will essentially tape 3 sides when you apply the dressing. And what that will do is, because this is an open chest wall injury where the pneumothorax is open to the environment, basically every time the patient will take a breath, it'll lower the intrathoracic pressure and lead to air from the outside environment going in and contributing to the pneumothorax. So the pneumothorax won't be able to resolve spontaneously. So the way you treat that is with the partially occlusive dressing, where when the patient breathes in, the dressing will be tight to the chest, and when the patient breathes out, they can get air out of the chest and into the environment. Again, so here's a example of a sucking chest wound, where you can see air is entering during inspiration, and during expiration it will exit, but because there's air entering during inspiration, it kind of evens itself out, so you're not able to expel air during expiration. So that's why you'll want that partially occlusive dressing. And here's just an example of what that occlusive dressing would look like on the left-hand side. So now let's say a patient presents with dyspnea, tachypnea, and you see hazy infiltrates 3 days following chest trauma. What is your diagnosis in this patient? So here you want to be thinking about pulmonary contusion, and management is typically supportive. Here you can see a chest x-ray with those hazy infiltrates on the right lung, and this would be consistent with a pulmonary contusion. Now let's say they give you a patient with persistent pneumothorax, subcutaneous emphysema, crepitus, and a persistent air leak a few days after admission, even after chest tube has been placed. What do you want to think about? What kind of injury do you want to think about in this patient? So you should be thinking about a tracheobronchial injury, so some kind of injury along the tracheobronchial tree that would be causing a persistent air leak, and management typically involves bronchoscopy. Another trauma indication for bronchoscopy can be a large hemoptysis, especially greater than like half a liter of blood. Here are some images of bronchoscopy with a tracheobronchial tree injury, and you can see that that laceration. It appears to be along the carina, kind of within the trachea. Next, we have ortho. Very interesting topic. Really pretty straightforward, which is good for exam purposes. So you can really earn a lot of points on these, and there are a lot of funny memes about ortho. So always a fun one to talk about. So let's say the examiners give you a 45-year-old gentleman presenting with severe right leg pain after a motor vehicle accident. His vital signs are stable, but you see the following imaging. What is your next step in management? So the first thing you want to do is assess if this fracture is open or closed. And why is this important? Because this is an example of an open fracture. It's really difficult to assess here, but that red arrow is supposed to be pointing out where the tibia is exposed to the environment. And it's really important to recognize open fractures on exams, because open fractures are more of a surgical emergency where you want to irrigate the area as soon as possible and initiate antibiotics as soon as possible. And typically for these open fractures, you want to consider open reduction internal fixation, probably with a plate on the tibia in this case, or a pin. But sometimes if the soft tissue is too swollen, then you'll want to first do external fixation before definitive open reduction internal fixation at a later date. And the external fixation, or the X-fix, would just be to reduce the fracture in the interim. Here's a picture of saline, and this is a picture, I told you SpongeBob has a lot of high utility frames, but here's an example of an open fracture. Here's Patrick. His pelvis looks a little different than human anatomy, but he is a starfish. I don't even know if they have bones. But anyways, you see these bones are exposed to the environment. So this is a good, memorable image for an open fracture. It's also high yield to note that the tibia has, I believe, the highest rate of osteomyelitis following an open fracture. So especially in this case, you want to follow the tenets of saline irrigation and early initiation of antibiotics to reduce the risk of osteomyelitis. Here's an example of an ORIF. This is a plate along the fibula. This is for an ankle fracture. Here is an image of external fixation. This is essentially a shattered tibia and fibula, so displaced bones with massive soft tissue swelling. So they opted for some antibiotic bead placement, you can see on the right hand side, and external fixation, where they actually will put in the rods and screws and just align the bone and let it heal and keep it reduced in the interim, and make sure there's some good skin healing, and make sure that the antibiotics beads are in place, and then they'll do definitive open reduction internal fixation at a later date. Here is what that X-fix looks like. So next, let's say they give you a 16-year-old patient that presents to the ED after falling on an outstretched arm during a basketball game, and they give you the following radiographic findings. So what is the diagnosis, and what is the next best step? So this is a elbow fracture. So in this case, or elbow dislocation rather. So in this case, you want to attempt closed manual reduction, and this can be done with or without sedation. So the basic 3-step method for orthopedic manual reduction involves 1, distraction of the fracture. Essentially, you want to provide traction and pull. You want to increase the deformity by bending, and then you want to decrease the deformity by straightening out the fracture, the dislocation or fracture. So here are pre and post films of the manual reduction. You can see the appropriate reduction of the dislocation. All right, let's say the next question is 89-year-old woman presenting with pain after a fall from standing height. On exam, you see that there's shortening of the left lower extremity and external rotation, and you see the following radiograph. What is your next step in management? So this is a hip fracture, and the first, there are some tenets of hip fractures, and they're a very common problem, especially in the hospital and for exam purposes. So the first step, of course, is to stabilize the patient, go through your ABCs, primary, secondary exam, and then you want to surgically repair any hip fractures, typically within 48 or 72 hours. And this is a very commonly tested topic, that surgical repair is almost always indicated for a hip fracture. Here is example. This isn't an OR image, but I think it's close enough for a lot of these orthopedic cases. But this is, just like in the previous image, this is some femoral nailing. I can't tell if this is a gamma nail, but typically nails are used for intertrochanteric fractures, but you can also use things like hemiarthroplasty or basically hip replacement surgery. So here is an example of what I just mentioned, the hip hemiarthroplasty, which essentially means replacing half of the hip. So you don't replace the acetabulum, you just replace the stem of the femur, so the head of the femur. Here's the different types of femur fractures. I won't really go into depth too much, but these are all kind of examples of femoral neck or intertrochanteric fractures. There is one subtrochanteric fracture, but again, these will be the most common femur fractures that you'll see. Again, it's really important to fix femur fractures, and femoral hip hemiarthroplasty is one of the major surgeries used because there is kind of a tenuous blood supply along the femoral neck. So there can be risk of non-union or malunion in a lot of femur fractures. So some more tenets of orthopedics. So here's a structure of a long bone. You have at the most distal end your epiphysis, the metaphysis where the growth plate is located, and the diaphysis is the shaft of the bone. And then you'll have cortical bone or compact bone on the outside, and then medulla on the inside. Here are some different types of Salter-Harris fractures. These can be high yield, probably more high yield on the pediatric shelf, but sometimes tested on the surgery shelf. So be familiar with these. Again, I just kind of remember that type 1 is a transverse fracture that's along the growth plate, but does not involve the growth plate. And then a type 5 Salter-Harris fracture is basically a crush injury involving the growth plate. So this is a very, very high yield scenario. So if you didn't pay attention to anything else on the shelf, I would pay attention, or this shelf review, I would pay attention on this question. Let's say the examiners give you a 40-year-old gentleman that has an unknown past medical history, that was admitted for a trauma, and now 2 days post-op after their repair of their tibia develops a seizure, hypertension, tachycardia, and agitation. What is your next step in treatment? And I'll give you a second to think about it. So you should be thinking about IV lorazepam, and that's because this presentation is consistent with alcohol withdrawal, which is very, very commonly tested on basically every single shelf. I don't know if any of you have seen this clip.
I will never quit drinking. I will never quit drinking. I will always make sure that I can keep my body healthy enough so that I can always drink. I love seeing a sunrise with a cocktail, seeing a sunset with a cocktail, having friends walk into your house with a bottle of wine, getting on a plane. Can I get you something? Double Jack on the rocks, lots of rocks.
Alcohol withdrawal and delirium tremens, very, very high yield topic. for every shelf, as I just mentioned. So basically within the first couple of days, then the patients can start having withdrawal symptoms, and delirium tremens kind of can begin around day, typically 48 hours, but in this diagram looks like 24 hours is when it begins, but kind of peaks around 72 hours or 96 hours. And this can actually be a life-threatening condition, so it's really important to recognize alcohol withdrawal and treat it appropriately with usually CWEL protocol. IV benzodiazepines are usually treatment of choice on the shelf exams, but some institutions will use things like barbiturates, like phenobarbital, because it has a bit of a longer half-life, or gabapentin is another alternative. All right. So in your orthopedic exam, so just the physical exam, you really want to think about the neurovascular bundle. So that'll involve your motor function with the motor nerves, your neuro with sensation, see if that's intact, and then see if there's perfusion in the injury or distal to the injury. All right, so our next patient is a 35-year-old that is 5 days post-op following femur fracture with open reduction internal fixation that now develops unilateral leg swelling, dyspnea, hypoxemia, and acute onset of pleuritic chest pain. What's your next step in management? So you want to get a CT angiography or a spiral CT to evaluate for pulmonary embolus. Now, one question you might get is, should you get a D-dimer? So this should be a resounding no for multiple reasons. One is because this patient is post-op. So in the post-op setting, the D-dimer will basically always be high. And number two is because this patient has a very, very high pretest probability of having a DVT or pulmonary embolus. So there's really no point in getting a D-dimer because it doesn't change your management at all. So how do we prevent DVTs and pulmonary embolus in the post-op setting? So if any of you have worked in the hospital, you know this one, but this is prophylactic anticoagulation, usually with Lovenox, so low weight molecular heparin. But if a patient is discharging, you can also consider like a DOAC, like a Pixaban, or even aspirin for some orthopedic injuries. Which type of surgery has the highest risk for DVT? Interestingly enough, it's orthopedic injuries. And then, of course, you should know about Virchow's triad. So Virchow's triad, again, is any alteration in blood flow, hypercoagulability, and damage in endothelial cell damage. So that triad is kind of responsible for, or is a very commonly tested triad for the formation of blood clots. Now, let's say you have a 35-year-old, 2 hours post-op following femur fracture repair that now develops dyspnea, hypoxemia, altered mental status, and importantly, a rash, specifically petechiae over the chest. What is your diagnosis? So you should be thinking about a fat embolus, especially with the petechiae over the chest. And the management of fat embolus is supportive treatment. So here I found some criteria. This is the Schoenfeld scoring system for fat embolus syndrome. And you see that the petechial rash actually has 5 points attributed to it, and everything else. So diffuse infiltrates on chest x-ray is 4 points, hypoxemia is 3 points, fever, tachycardia, tachypnea, and confusion all are 1 point, and 5 points are required for the diagnosis. So you really want to be looking for a rash in distinguishing fat embolus syndrome from a pulmonary embolus, because that can be often very difficult in questions regarding orthopedic care. All right, next, let's say that they give you a 70-year-old postmenopausal woman with a fragility fracture. What is the most likely predisposing cause or predisposing diagnosis for this incident? Predisposing diagnosis is osteoporosis, and some other examples of fragility fractures include femoral neck or IT intertrochanteric fractures, distal radius fractures, or also vertebral compression fractures. And some modifiable risk factors for osteoporosis include low BMI, low physical activity, low vitamin D or calcium intake, and then alcohol and tobacco use. So this is very high yield for exams. And some treatments, common treatments for osteoporosis include our bone drugs. So that can include the most common being bisphosphonates, but also things like raloxifene. And then if a patient has hypertension and osteoporosis, you can consider hydrochlorothiazide because that increases calcium absorption at the distal convoluted tubule. And also they're like zoledronic acid or denosumab as well, you can consider in osteoporosis. Some drugs that increase the risk of osteoporosis. So what kind of drugs would increase risk of osteoporosis that are commonly tested? So these would be your steroids, heparin, protein pump inhibitors, aromatase inhibitors, and anticonvulsants. The way anticonvulsants work in increasing osteoporosis risk is they activate cytochrome P450. So these patients will have higher vitamin D catabolism. In the general population, what is the screening criteria for osteoporosis? So at age 65, a screening DEXA is recommended, and then a T-score of less than -2.5 is diagnostic of osteoporosis. And as I mentioned, treatment involves typically pharmaceutical treatment with bisphosphonates or denosumab, which is a monoclonal antibody, but also calcium and vitamin D supplementation, weight-bearing exercise, and you can consider raloxifene and hydrochlorothiazide. Some examples of bisphosphonates are alendronate, pamidronate, or zolendronate. Anything with ronate would be a bisphosphonate. And the mechanism of action is that this acts as a pyrophosphate analog. So these medications decrease osteoclast recruitment and bone absorption. They essentially induce apoptosis of osteoclast because the osteoclast, which are the cells that break down the bone, take in the bisphosphonates, the pyrophosphate analog, but that causes apoptosis within the cell. So some common adverse effects of bisphosphonates. So esophagitis, or more specifically piloesophagitis, but also GERD, essentially reflux disease, is very common with bisphosphonates. So in patients on bisphosphonates, we recommend they sit upright for like an hour after taking the medication. Also osteonecrosis of the jaw and hypocalcemia. Here is a diagram of peak bone mass. So it's the most important part to note from this diagram is that males and females are more commonly tested, but they reach their peak bone density around age 30. And from that point, there is bone loss, especially postmenopausal. All right, let's say the next patient is a 35-year-old, 2 days post-op following fixation of the tibia that suddenly develops extreme pain. On exam, you see extreme pain with passive ankle flexion and kind of a tense lower leg. What is your next step in treatment and your diagnosis? So your diagnosis will be compartment syndrome. And what is your next step in management? So do you want to obtain tonometry or compartment pressures? No, you should do emergency fasciotomy. So this is a clinical diagnosis. So what is the pathophysiology of compartment syndrome? So essentially in compartment syndrome, you get increased tissue perfusion that is greater than the perfusion pressure. So there's so much extra cellular, extravascular fluid that the hydrostatic pressure is greater than that of the perfusion supply. So the cells don't get perfused, essentially. So some exam findings that you'll see in the early stages of compartment syndrome. So you'll see severe pain, especially with passive stretching, paresthesias, tense swelling, and then for some late findings, these will be your 6 Ps. So that'll be pallor, pain out of proportion, paresthesias, pulselessness, poikilothermia, and paralysis. Again, I put late, open parentheses, call your attorney, because once a patient develops these symptoms of the 6 Ps, then a lot of times this damage is more or less irreversible. So you really want to identify compartment syndrome as early as possible. So complications of compartment syndrome, what do you want to be thinking about in terms of complications? So you should be thinking about AKI or acute kidney injury, because these patients are experiencing muscle necrosis, so they can get rhabdo and then irreversible damage after 6 to 8 hours. Here is just an image of the compartments of the leg. Now let's say we have a similar presentation of a patient with a past medical history of atrial fibrillation, now presenting with acute onset limb pain. On exam, they're in severe pain. There's pallor of that limb. They have diminished pulse, weakness, and pain with passive range of motion. What is your next step in treatment for this patient? What's your likely diagnosis? So you should be thinking about anticoagulation, probably with IV heparin. And this would be an example of acute limb ischemic, probably due to a cardioembolic source, likely from the atrial fibrillation. Next, let's say we have a 55-year-old gentleman presenting with leg pain after a GSW to the leg. On exam, you note diffuse bleeding, a cool distal extremity, and absent distal pulses. What is the next step in management? So this is a surgery shelf, so the next step in management is indeed surgery. And that's because this patient is exhibiting hard signs of vascular injury. So any hard signs of vascular injury warrant emergent surgery. So these hard signs include distal limb ischemia, absent distal pulses, active hemorrhage or rapidly expanding hematoma, any bruit or thrill at the site of injury. And then the soft signs include diminished distal pulses, but not absent. Again, absent distal pulses are a hard sign of vascular injury. Any unexplained hypotension, any bony injury, any known hemorrhage, or neurologic deficits. So again, if there are any hard signs of vascular injury present, that's an indication for surgery. If there are no hard signs present, then you could have time to obtain further imaging. So typically that involves CT or CT angio, but you can also consider ABIs and ultrasound with duplex Doppler. For our next patient, let's say we have a 55-year-old gentleman presenting with right knee pain. On exam, you see that this patient has a unilateral knee effusion and the joint is warm and red. This joint is painful with passive and active motion, and also is tender to palpation. What is your differential diagnosis for this patient? Talking about septic arthritis, gout or pseudogout, rheumatoid arthritis, and any hemarthrosis. So that's, but again, your most likely differential diagnosis should be septic arthritis and gout or pseudogout, which are inflammatory causes. So what will be your next step in management for this patient? So you should be saying you'll tap the joint with the arthrocentesis. And here's an example of what arthrocentesis looks like. Essentially, you're just going to tap some of the fluid. Here are some diagnostic criteria for the analysis of the joint fluid. So normal synovial fluid should have less than 200 white blood cells and be clear in appearance. Non-inflammatory fluid is clear or straw colored and has less than 2,000 white blood cells. An inflammatory etiology would have greater than 2,000 white blood cells and still be clear or cloudy. And a septic joint would be grossly cloudy or filled with pus and have greater than 50,000 white blood cells is typically the cutoff. Although in patients with a prosthetic joint, you can go even as low as 10 to 15,000 white blood cells should be concerning for a septic arthritis. So speaking of septic arthritis, what is the most common bug that causes septic arthritis? So that would be Staph aureus. Some other bugs that cause septic arthritis. So group A strep, staph epidermidis, especially in prosthetic joints, other gram-negatives, especially like the Hayseck organisms, and then Neisseria can cause septic arthritis, especially in younger patients. So some risk factors for septic arthritis: any abnormal anatomy of the joint, so osteoarthritis, rheumatoid arthritis, prosthesis, immunocompromise, and bacteremia as well. And what is the next step after synovial fluid analysis, or what's part of the synovial fluid analysis? So that's gram stain and culture. And then treatment of septic arthritis, what will that involve? So that will be empiric IV antibiotics, and then you want to do a joint washout and drainage of that joint to prevent further joint damage. So empiric antibiotics typically involve vancomycin to cover for potential MRSA, because staph is the most common bug, and then ceftriaxone should cover for any of the gram negatives or Neisseria that can cause septic arthritis. All right, let's say we have a 20-year-old football player that's tackled and then lands onto their shoulder. On exam, you note that they're tender over the AC joint, and then on the cross body abduction test, they have a positive test, or they have pain. So what is your suspected diagnosis in this patient? So this is an AC joint sprain, or a acromioclavicular joint sprain. And you want to obtain what imaging study to make this diagnosis? So you just want to get a x-ray of that joint, and the treatment involves a sling, and you can consider surgery if the injury is more severe. Now, let's say we have a similar case. So let's say we have a 20-year-old football player that's tackled and then falls onto his shoulder. On the exam, you note that his arm is adducted and externally rotated with lateral shoulder numbness. So what is your diagnosis for this patient? So you should be thinking about axillary nerve injury due to shoulder dislocation with excessive abduction and external rotation force. So this is a clinical diagnosis, but you should obtain a shoulder x-ray to rule out any other injuries. And treatment will be typically close reduction with distal traction and external rotation of the humerus. Now let's say we have another 20-year-old athlete, just full of 20-year-old athletes on this exam, that hits an electrical pole and has a seizure at the same time. So a very unlucky sequence of events, a series of unfortunate events, some would say. Now this patient has left shoulder pain. On exam, you note that his left shoulder is adducted and internally rotated. So what is your diagnosis for this patient? So here you want to be thinking actually about a posterior AC subluxation or shoulder dislocation. And the common buzzwords for that will be your electrocution, so hitting an electrical pole, and also seizures can predispose patients to posterior AC subluxations. Here's a shoulder series of AP and lateral view of a shoulder dislocation. Now, hopefully this is the last 20-year-old football player that we see, because I'm starting to get sick of this vignette. But let's say we have a 20-year-old football player that's tackled, falls onto his shoulder. On exam, you see swelling, erythema, and tenderness of the anterior shoulder. What is your diagnosis for this patient? So I'm trying to go for a clavicular fracture here, but we'll just kind of briefly discuss clavicular fracture. So most common location on the clavicle for fracture is a middle third, and the most common displacement pattern is when the deltoid will pull the clavicle inferolaterally, while the SCM, the sternocleidomastoid, will pull superior medially. So that's why a clavicle fracture can become displaced. So treatment typically involves conservative management with a sling, but surgery is indicated if there's evidence of neurovascular compromise, or if there's evidence of the fracture being an open fracture. So there are some complications to clavicular fractures that because just deep to the clavicle, of course, if you remember your anatomy of the subclavian artery, so and venous and veins, and also the brachial plexus is kind of at the lateral end of the clavicle. All right, here you have an image of a displaced clavicle fracture. And here is an image of a humeral neck fracture with humeral head dislocation. And why is a humeral neck fracture very high yield on exams? What complication can arise from a humeral neck fracture? So you should be thinking of a disruption of the circumflex humeral artery, which can lead to AVN, and then you can also get axillary nerve injuries. All right, so and just going back one slide with the humerus. So you also want to remember that with humeral shaft fractures, there can be damage to the radial nerve. All right, so moving on to some hand trauma. Let's say they give you a 65-year-old woman that presents after a fall on the outstretched hand. Now, with thumb pain on your exam, you note tenderness to palpation in the anatomic snuff box. What is your likely diagnosis for this patient? So you should be thinking of a scaphoid fracture. And some imaging you want to obtain is a hand x-ray. But what happens if your immediate x-ray is negative? Will you just send them home and then tell them to follow up when they feel like it? So you will want to repeat a hand x-ray in 2 to 3 weeks if you have a high clinical suspicion of a scaphoid fracture, because there's often risk for avascular necrosis and non-union because of the tenuous blood supply to the scaphoid bone. Treatment will involve a thumb spica cast or internal fixation if the injury is unstable. All right, next we have a postmenopausal woman presenting with a Fuchs injury with wrist pain. You see the following x-ray on the screen. What is your diagnosis? X-ray, you can see, let's see if I can hover somehow. Let's do laser pointer. So right here, you can see that there is a distal radius fracture. So that's also called the Colles fracture. And again, this is often predisposed by osteoporosis in these patients. So this is an example of a fragility fracture. And treatment typically involves close reduction with cast, or if the fracture is unstable, then internal fixation. Now, next patient that, let's say the examiners give you a 50-year-old woman that is presenting with a 3-month history of pain and tingling in her hand. On exam, you note numbness in the thumb and the first 2 digits and a positive Tinel sign. This patient works as a keyboarder. What is your diagnosis? And again, the Tinel sign is when you are able to reproduce the symptoms with, I believe it's tapping or compression of the affected area. So what is your diagnosis for this patient? So you want to be thinking about carpal tunnel syndrome and a little more about carpal tunnel syndrome. So some commonly tested risk factors are pregnancy, rheumatoid arthritis, hypothyroidism, lunate dislocation, and B2 microglobulin deposition. So that is, I believe it's associated with amyloidosis in dialysis patients, so they can get carpal tunnel. It's also associated with human growth hormone, acromegaly. So some other features on exam are, so these patients will experience symptoms in the median nerve distribution. So you can also see thenar eminence atrophy, weakness of thumb, abduction, flexion, and opposition, and then a positive Tinel and Phelan sign. So I believe Tinel sign is the tapping sign, because I remember T in Tinel and T in tapping. So diagnosis is typically clinical, but you can also obtain an EMG or other nerve conduction studies if you are not convinced of the diagnosis. So what is typical treatment for carpal tunnel syndrome? So typical treatment involves activity modification and also splinting, but also steroid injections. And then the surgical definitive option is a carpal tunnel release procedure where you are essentially releasing the transverse carpal ligament. Now let's say we have a patient presenting with a superficial palmar laceration with a median claw hand, loss of thenar muscles, and intact sensation. What is the diagnosis in this patient? This is a very specific question, so we'll just go over it quickly, but this would be an injury to the recurrent branch of the median nerve. So the superficial branch is intact, so these patients still have intact sensation. All right, so next, let's say they give you a 40-year-old patient that's a competitive cyclist with pain and paresthesia in the 4th and 5th digits. So what is a likely diagnosis in this patient? This specific syndrome is compression at the ulnar wrist because this is a cyclist, so they'll be putting pressure kind of on the lateral wrists. So on exam, this will involve sensory loss in an ulnar distribution, hypothenar atrophy, and then a positive Tinel sign at the Guyon canal. Treatment, again, involves activity modification, bracing, and analgesia. Let's say there's a carpenter that has repetitive hammer use presenting with similar symptoms. This patient could also be a dialysis patient. So this is cubital tunnel syndrome. And the cause of this is actually ulnar compression at the elbow. So the way you want to distinguish those is by the patient history. So in both cases, the ulnar nerve is affected, but test examiners love to go after this, where they want you to distinguish between Guyon canal syndrome or ulnar, which is ulnar compression at the wrist, and cubital tunnel syndrome, which is ulnar compression at the elbow. So at the elbow, so some patients that are more high risk for chronic compression of the elbow are your dialysis patients because they'll have their kind of arms on the armrest, or kind of carpenters with repetitive hammer use. All right, so these will be some quick cases. So just kind of say the answer in your head as I read these off. So let's say we have a patient with forced hyperextension of an actively flexed DIP joint. So on exam, the patient can flex the MCP and the PIP, but not the DIP. What is your diagnosis? So this is Jersey finger, and that's when you have rupture of the flexor digitorum profundus tendon. Now, next patient, let's say you have forced flexion of an actively extended, or kind of when your hands are out at the DIP. Let's say the patient's finger is flexed when attempting to extend all their fingers. So what is the diagnosis here? So this would be a mallet finger, which is a rupture of the extensor tendon. All right, and then another common complaint or commonly tested vignette is, let's say a patient has non-traumatic progressive pain, clicking, and most notably catching and locking of one of their digits. What is the most likely diagnosis? So this would be a trigger finger. Now, another just miscellaneous fact while we're on the topic, let's say a patient has an abscess in the pad of their finger after a penetrating injury. What is the diagnosis? What's the name of this called? So this is called a phelon. All right, moving on. So let's say we have a 35-year-old woman presenting following a motor vehicle accident. This patient is in severe pain, and in the trauma bay, you note that the exam is significant for a shortened and internally rotated hip that's held in flexion and adduction. What is your diagnosis? So this is a posterior hip dislocation. But again, yeah, you should also be thinking of a hip fracture. So your next step will be x-rays, and then you'll want to reduce the hip dislocation to reduce the risk of AVN, or avascular necrosis. And complication you want to be looking out for is sciatic nerve or inferior gluteal nerve injury. Some other complications include labral tear and arterial injuries. And here are some quick examples of those dislocations. So this is a x-ray of the pelvis. So now we have another patient that was involved in a motor vehicle accident. X-ray shows posterior knee dislocation. What's the next step in management? So you want to first do a vascular exam and ABIs, and then duplex ultrasound if that's available. So you want to assess for vascular, if there's a vascular injury. So then you want to consider reduction, and that's because the popliteal artery is often injured. And if there is evidence of vascular involvement with ABI of less than 0.9, you want to obtain a CTA and then a vascular surgery consultation. Another common complication is common peroneal nerve injury. So that's because you can have injury to the lateral fibula, which is the kind of where the common peroneal nerve wraps around. All right, another case of trauma to the knee. Let's say a patient suffers direct trauma to the anterior knee, and now they're presenting with knee pain and limited range of motion. On exam, you note severe tenderness to palpation of the anterior knee and with knee extension, and they cannot extend the knee against gravity to a full 180 degrees. So what is your diagnosis? And here is the x-ray. So this is a patellar fracture. So treatment of patellar fracture typically involves kind of splinting or a leg brace, but if the fracture is poorly reduced or open, then it will require fixation. All right, so some common knee exam maneuvers. So just kind of go over these in your head and try to determine what each of these maneuvers are testing for. And they'll mostly be ligaments or things like that within the knee. So knee structures. So anterior drawer and Lockman. This tests for ACL tears or injuries. Posterior drawer test, PCL injuries, valgus laxity, MCL injuries, varus laxity, LCL injuries. Internal rotation and the varus McMurray test. That tests for the lateral meniscus. An external rotation and a valgus McMurray test. That tests for medial meniscus injuries. Some common mechanisms of injuries. That'll be direct blows, deceleration, pivoting and cutting in sports. To diagnose any ligamentous injuries, what's kind of the first line imaging study? You want to be thinking of getting an MRI. And then treatment typically involves, depending on the injury, activity modification, analgesia, or even surgery for repair. All right, some signs of meniscal tear. That can involve catching and locking or reduced range of motion. Treatment is typically conservative if it's mild, without impaired activity, or if it's an older patient. Otherwise, surgery for either meniscus repair or meniscectomy, where the meniscus is excised. Some special fractures. So what's it called when a fracture causes an incomplete fracture due to bending stress? So that's a green stick fracture, because I don't know if you've ever had like a kind of tried to bend a young green stick or a young twig. The fracture or the kind of bending will not extend throughout the entire length of the twig. It doesn't just snap in half. And it's kind of the same with bones. So you can remember this is more common in kids. Let's say axial force causes a buccal fracture of the cortex. This is a torus fracture. And then a spiral fracture in an ambulatory children due to a twisting injury. This is a toddler's fracture. Now, another common situation, let's say they give you a 3-year-old patient that's yanked by their arm with elbow pain, and when you see them on exam, they're holding the arm close to their body with the elbow in flexed and pronated. So this is a radial head subluxation or nursemaid's elbow, and the pathophys of that is that young children have an immature annular ligament, so they can be injured with traction. Treatment is with reduction with hyperpronation or supination with elbow flexion. So the way I remember that, I know it's a lot of big words, but I just remember the hyperpronation is kind of like the whip. So you will hyperpronate that. I remember when that dance was real popular, but maybe I'm just showing my age. So now let's say the examiner is give you a 5-year-old that presents after a Fuchs injury and they have an obvious deformity at the distal humerus. Vital signs are stable. What is your next step in treatment? So this is a supracondylar fracture, and some high yield associations are high risk of median nerve and brachial artery injury and radial nerve damage if it's an anterior lateral displacement. And something you want to be worried about is Volkmann's ischemic contracture if there's a brachial artery injury. So treatment of this would be a surgical fix with fixation. We have a 60-year-old gentleman that's presenting with bone pain, headache, and hearing loss that developed in the last few months. What is the likely diagnosis for this patient? So this is Paget disease of bone, and this is caused by disordered bone remodeling. The main lab you want to be looking out for is elevated alk phos, but really just isolated elevated alk phos. A lot of the other labs will be within normal limits. Treatment typically involves bisphosphonates and calcitonin. Some common complications of Paget disease that are commonly tested. So that can involve fractures, but also high yield to nose that it predisposes to osteosarcoma. Let's say we have a 65-year-old gentleman presenting with foot pain and they have a history of diabetes, and you see their x-ray below. What is the diagnosis for this patient? So this is a Charcot foot or Charcot neuropathy, and on the x-ray you can kind of see disorganization and fragmentation of a lot of the joints, like especially the subtalar and intertarsal joints, and there's also some bone fragments, and this is essentially due to kind of chronic trauma. So let's talk a little bit about neurogenic Charcot arthropathy. So there's a classic progression which kind of starts with impaired sensation due to microvascular injury due to diabetes, where you get repetitive soft bone and soft tissue trauma because you can't really feel pain as well within the joint. So then you get repetitive inflammation, bone resorption, abnormal weight bearing, and then finally ulcers, osteomyelitis that often requires amputation. But again, first line treatment can be a foot cast to really make the joint non-weight bearing. And then from that point, you want to evaluate how the patient heals with the non-weight bearing conservative management. But ultimately, some of these patients will require amputation if there's chronic non-healing and chronic non-healing wounds. All right, so let's say a patient presents with toes that are stuck in dorsiflexion at the MTP and plantar flexion at the proximal and distal IP joints in a diabetic patient. What's the diagnosis? So this is a claw toe deformity, and that's because of atrophy of intrinsic foot muscles due to degenerated motor axons, and then also decreased pain sensation and proprioception, most commonly associated with diabetes. Let's say you have a 25-year-old basketball player that presents after hearing a pop while playing. On exam, they're unable to dorsiflex the right foot, and they have a positive Thompson test. So the Thompson test is when you squeeze the calf and there's no plantar flexion. So what is the diagnosis here? So this would be an Achilles rupture. So typically the diagnosis can be made clinically, but you can obtain an ultrasound or MRI to verify the diagnosis. And treatment is often surgical repair, although non-operative approaches are an option in selected patients. So famously, Kevin Durant had an Achilles injury in the NBA Finals against the Raptors. And this was the little dance he did before that game, actually, which I did watch live, unfortunately. So, yeah, this is when he was on the Warriors. All right, we move on. So next, let's say the examiners give you a 21-year-old woman presenting with foot pain. She's a runner and she's describing some burning pain, numbness of her ankle, heel, sole, and toes. And this pain is worse with weight bearing. On exam, she has a positive Tinel sign, right? The tapping sign over the posterior medial malleolus. And the pain is worse with dorsiflexion, with an eversion, and plantar flexion and inversion of the ankle. What is your diagnosis? So this is tarsal tunnel syndrome, and it's typically a clinical diagnosis, although nerve conduction studies can help. And what is the treatment for this syndrome? So treatment typically involves activity modification, orthotics, analgesia, and then ultimately surgical release if this is refractory to all of those conservative measures. Next, let's say they give you a 55-year-old woman presenting with 1 week history of acute back pain. She reports pain throughout the day. It's not improved by rest or position, and she's had some fever, chills, and night sweats over the last couple of weeks. Now she's noting new weakness of her left leg that started yesterday. What is your next step in management? So you should be wanting to obtain some stat imaging, probably a stat MRI, and then also an ESR to CRP, CBC as well, to assess for leukocytosis and infection, because you're concerned about what diagnosis. So you should be worried about an epidural abscess, but also you'll be worried about things like malignancy. Treatment, again, this is a surgery shelf, so surgical debridement, so you want to call neurosurgery, and then also IV antibiotics that you want to initiate as soon as possible. Sometimes on the boards, one predisposing that can be done prior to epidural abscess, or one predisposing clinic procedure can be a epidural injection. All right, so some commonly confused spinal emergencies. I won't belabor this too much, but essentially you want to know the difference between conus medullaris, which is symmetric motor weakness, and then cauda equina, which is more asymmetric. For both of these, you want to diagnose with MRI and do treatment with surgery and steroids. Moving on. Let's say we have a patient presenting with fever, chronic insidious back pain, and sinus tract formation. On exam, you note tenderness to palpation of the midline back. There's no radiculopathy or weakness, and they have an elevated ESR. What is your likely diagnosis for this patient? Factors, so I'll just quickly go over these, but hematologous seeding, contiguous spread, any penetrating injury, immunosuppression, and also sickle cell, because you can get end vasoconstriction and ischemia, which predisposes to osteomyelitis. Some common bugs, just like with any infection, Staph aureus, but also coag-negative staph, Pseudomonas, and Salmonella. And then with your imaging of choice, so you want to start with the chest, with the X-ray of the spine, but ultimately MRI will probably be the best test for osteomyelitis in terms of imaging. Treatment typically involves first bone biopsy and then initiating antibiotics after the biopsy. Let's say you have a postmenopausal patient presenting with focal back tenderness and pain with bending, coughing, sneezing, or lifting. On exam, again, they have focal tenderness but no focal neurologic deficits. What is your likely diagnosis? So this is concerning for a vertebral compression fracture, and the predisposing factor, like we've mentioned a couple of times now, is osteoporosis. Treatment of vertebral compression fracture is typically kind of supportive, so with pain relief or activity modification. There is one high-yield medication, which is intranasal calcitonin, which can reduce pain in the acute setting. Next, let's say they give you an older patient with a history of cancer, and their back pain is worse at night and unrelieved by rest. What is your likely diagnosis in this patient? This is concerning for kind of metastatic cancer, to the spine. We move on. Let's say we have a 55-year-old woman presenting with low back pain. She describes paresthesia and weakness in the leg, and then on exam, she has a positive straight leg test. She does not have any fever or chills. What is the likely diagnosis? So this could be concerning for a herniated disc, and the pathophys is usually due to posterolateral disc herniation of the nucleus pulposus through the annulus fibrosus. Diagnosis is typically clinical, but MRI can be obtained if bilateral symptoms or if they have neurologic dysfunction. Treatment, again, typically activity modification, NSAIDs, physical therapy, and other supportive treatment. But if pain is still present 4 to 6 weeks later, you can obtain an MRI to assess for surgery. And then there is one muscle injury that can present similarly, and that is piriformis syndrome, which is hypertrophy or injury to the piriformis, which can compress the sciatic nerve and can look very similar clinically to a herniated disc. We move on. So let's say the examiners give you a patient that's presenting with radicular arm pain with sensory motor defects across multiple nerves. What is the likely diagnosis here? And it's worse with kind of neck flexion. Is cervical spondylosis. You can obtain an X-ray to identify degenerative disease and osteophytes, or also an MRI to assess for cord compression. Treatment typically involves analgesia and surgery if severe. All right, this next vignette I guess I just gave to you, but this is a 65-year-old gentleman presenting with a shopping cart sign. What is the likely diagnosis? So that would be lumbar spinal stenosis. And it's commonly relieved with leaning forward because of the narrowing of the spinal canal is relieved, and the spinal canal is less narrow when the patients lean forward and there's flexion of the spine. MRI to assess for degree of stenosis and cord compression, and treatment typically involves physical therapy and then surgery if it's refractory. We move on. So next we have an adolescent male presenting with proximal femur pain that's worse at night. It does improve with NSAIDs, but is unrelated to activity. What is the likely diagnosis? This is an osteoid osteoma, and that's because the pain improves at night with NSAIDs. An osteoid osteoma because the pain improves with NSAIDs. On X-ray, you'll see a small round lucency, and then treatment typically involves NSAIDs and consistent monitoring. Now, a similar patient with pelvis or long bone swelling that's worse with activity does not respond to NSAIDs, and they have fever, chills, and night sweats. What is the likely diagnosis in this patient? So here you'd be concerned about a Ewing sarcoma, and on X-ray you may see the moth-eaten appearance and that onion skinning due to new subperiosteal bone formation. All right, we're almost at the end of these slides. So let's say you have a patient with chronic localized pain and soft tissue mass at the metaphysis of a long bone. They have fever, chills, and night sweats, and a history of radiation. What's the likely diagnosis in this patient? This is a osteosarcoma, and again, it's associated with a few gene mutations, mostly the RB and P53 gene mutations, Paget disease, and then prior radiation. Some X-ray findings include the sunburst pattern. That's due to the periosteal reaction, and also Codman triangle, which is the raised edge of ossified periosteum. All right, last couple of cases. Now we have a 30-year-old gentleman with pain, swelling, and stiffness in the right forearm. The X-ray findings are below. So you can kind of see that lytic lesion on the distal radius. So what is this concerning for? So this is a giant cell tumor of bone. So on the imaging findings, you'll see these lytic lesions with a soap bubble appearance. And on diagnosis, you'll see multinucleated giant cells on biopsy. Treatment typically involves surgery, but these can be locally aggressive and have a high rate of occurrence. All right, so that'll do for our cases. Thank you all for watching. And if you enjoyed, please make sure to like and subscribe.